Okay. All right. Thank you, Joe. So calling the meeting to order of our monthly Behavioral Health Board, County of Humboldt. And so I'd like to start with the call the roll call. I'm losing my mind here. Roll call, introduction of staff and guests. And what we'd like you to do for everyone is, as you tell us your name, then tell us the your preferred pronoun you want to be used with that. And so, as I've said before, Joe, give us time to say that as well. We start with the roll call, and that is of Behavioral Health Board meetings. Joe, can you do the roll call? Joe, we can start with the roll call now.
Joe's muted.
Joe, oh, there we go. Joe, can we start with the roll call now?
I think Joe said he couldn't hear us.
No, that was Tim Ash.
Oh, okay.
So, but maybe I'm wrong. Joe, can you hear us? Then I have a question. Can the minutes be made if we don't have a secretary recording them? So Joe is really very quick to respond and share.
Kim, are you able to hear us at this point?
I can hear everyone, but Joe, can you hear
Tim
us?
Ash, it
Yeah.
looks like he can't. And so I'm
Tim-
guessing Joe is having a similar issue. That's what I'm thinking.
So Joe, can you, if you can hear me, can you nod your head that you can hear me?
Yeah, he can hear you. He just doesn't have a microphone.
Okay.
He was talking.
Okay, so then the roll call, I'm not sure how we want to proceed to do that. I suppose that I can get it started, but not as well as Joe. And so as of the members, I'm just going to go down the names. Tim Doty is here, and he and him. And then Alyssa Norman,
Here, she, her.
Laura Montagna,
Here, she, her.
Madison Flynn said she couldn't be here. Steve Madrone.
Here, he, him.
Okay, and Tim Ash is here. Tracy Connor. Allison Tans.
Here, she, her.
Thank you. So we have new members who've just been approved a couple of days ago by the Board of Supervisors, and that would be Debbie Hartridge
Here, she, her.
and Isabella Witherspoon.
Present, she, her.
Okay. Did I miss any board members? I can. All right, let's go on to the staff. Will you just go ahead and pick who wants to share with us that you're here first? Please introduce yourself to us.
Hi, Emmy Botzler Rogers. I'm the Behavioral Health Director, and she, her.
Hi, Paul Bignacki, he, him. I'm a Deputy Director of Behavioral Health.
Kelly John.
Deputy Director, Behavioral Health.
Go right ahead, Kelly.
Sorry, Jack. I'm Kelly Johnson. I'm a Senior Program Manager at Adults Behavioral Health. She, her.
Okay, thank you. Maybe it's better if I go through the screen. I can see you. Kathy Rigby, can you introduce yourself?
Hi, Kathy Rigby, Program Manager, Mental Health Services Act Coordinator.
Great.
She, her.
Thank you. Julie, how do you pronounce your last name? Presboria?
Oh, very close. Julie Prezapora, Assistant Director of Nursing for County Behavioral Health, she, her.
Thank you. Connie? Director Connie Beck.
Hi there, I'm Connie Beck, Health and Human Services
Director for the county. She, her. Good to see everyone.
Thank you. Sonia.
Hi, Sonia Levy Boyd. I use she, her. I supervise the Humboldt County Transitioning Youth Collaboration in the peer coaches at the TAY Division.
Thank you. Laurel Johnson.
Hi, I'm Laurel Johnson. I'm an analyst who works in Health and Human Services Administration, and I go by.
Okay. Christine Messenger.
Hi there, I'm Christine Messenger. I'm with the DHHS Communications Group, and I use she and her.
Thank you. Sharon Wolf.
Hi, I'm Sharon Wolf, DHHS Legislative Analyst. Preferred pronouns are she and her, and it's good to see everybody.
Good to see you. Jack.
Sorry, I think I went, but I'm Jack Brazil, Deputy Director, Behavioral Health.
Thank you. Kelly Johnson.
I went, I'll pass it to Cassie Lathine.
Okay. I'm just going through the list of names. Dethen, is that, I pronounced that right?
Lathine, it's fine.
Okay.
No worries. It's my name's Cassie Lathine, and I'm a supervising clinician at Behavioral Health for mental health services in the jail and for the adult mobile response team.
All right, thank you. And I see Megan O'Connell.
Hey, Megan O'Connell. I am an attorney with Conflict Counsel. I'm just here observing today. Preferred pronouns are she and her.
Okay, thank you. It's an opportunity then. Philippa, you want to introduce yourself to us and talk a little bit about how you came on board and what you do.
Yes, hello everyone. Philippa Watkins, she, hers, and I am the Senior Program Manager and the Hospital Administrator for the Crisis Stabilization Unit and Semper Virens since November 1st. So this is my 3rd week.
All right.
I am a licensed marriage and family therapist and have managed in the past acute and forensic programs. I actually worked for Humboldt County in 2015 and 16 at same-day services and also at Crisis Stabilization Unit. And but then most of my career I spent in Sonoma County, where I went from forensics to quality assurance and performance improvement to the Crisis Stabilization Unit, and also was a program manager for an outreach program. So I moved around a lot and learned a lot about the population. I know some of the folks, I know Kelly and I know Cassie and some of you folks, and I'm excited to be here. I moved back here. The reason why I took this job is there's several reasons. Obviously, I moved back here, but there's really good folks working here. And I think we've always done a really good job trying to serve this community. And that was for me probably the main motivation to start working with Humboldt County again. And then a little bit about me, and folks who know me know that I am a very big client advocate, and we see clients, obviously my programs, especially in crisis. I think there's a lot of opportunity in crisis. And I also am a very strong staff advocate because I think that my staff needs to have the support and skills to do the job that they do, to provide the support and safety for people who need support and safety. So these are two things I think that describe me really well. And I perceive myself as a public servant, and I take this responsibility very, very seriously, and I see this as a great honor.
Thank you. Thank you very much. I really enjoyed hearing all about that. And, welcome. We're glad to have you on board. So we move on then to members of the public, and what I see on my screen is one. Now things have bounced around. Members of the public.
Sorry to interrupt, but hi, Tim, it's Madison. I was able to join the meeting a few minutes late. I can do a quick introduction.
Yes, a real quick one. Yeah.
Hi, my name is Madison Flynn. I go by she, her. I am a community member. I'm also a behavioral health board member.
Right. Thank you. I saw Dr. Katie Wilson up here.
Yep,
And
I'm also joining. Hello. And I prefer she, her. And I was thinking as far as the notification about the meetings being recorded, maybe that could be put on the invite. So when the public gets the email with the invite and the link, it could just, also include that it is a public meeting per the Brown Act and it is recorded. Thank you. I'll just be on mute.
Okay, thank you. Send that to Joe. Makes sense to me. If we need to pick it up with the next executive committee, we need to, but that sounds like a good idea. So we're done with our basic introductions and
Hey, Tim.
Yeah.
Hi, it's Emmy. I mean, just really quickly, and maybe it is an item for our next meeting. I think just to go back to the recording for 1 minute, and I'm certainly not the decision maker about that, whether or not that happens, but my recollection from our exec meeting was that it was going to be a discussion with the larger board to make sure, and I think that's probably a fair step to take so that the board can all kind of weigh in on that as a larger group, and then whatever decision, of course, is how it should roll forward. And I appreciate the suggestion by Dr. Wilson about being very clear and disclosing to members of the public that it is going to be recorded. But I do think that that's where we landed with the exec board, was that we would bring it to the full board to have a discussion and make sure everybody had the same perspective about it.
I agree.
So respectfully, Emmy, have you guys looked into the statute? Because I know that the actions of the BHB are specifically outlined by statute in this, according to the state. So I would think that it's not the choice of the local levels, but rather whatever the state.
I want to interrupt here right now, Dr. Wilson, because
Sure.
we put that on their discussion. I mean, we're just moving on the beginning of the agenda. So in the changes in the agenda, everybody knew that we're going to move up our presentation earlier, and that is on the agenda. Decision at the executive meeting. And I guess I want your permission to have the discussion on the recording of our meetings in item 8, which are discussion items only, no agenda voting. Is that all right with everybody to put that on there, Mr. Ash? I can't hear you. So.
You're muted, Tim.
Can you unmute, Mr. Ash?
I'm working on it. It's a difficult task. What I was saying is, no, I don't think we can have a discussion about it, regardless of whether there's a vote. But we can set it for the next meeting that we have. The one thing that I would add is, if we're going to agendize it for some future meeting, maybe somebody could check and see if what Dr. Wilson was suggesting is in fact the case in terms of any mandates.
Thank you. I appreciate that, and I think you're right about procedures, and so it is not on the agenda for today. And then the executive committee will make that decision and bring all our different ideas to do it correctly, so that you can all be a part of that discussion.
So with that, just looking for some direction, Tim, do you want this meeting to be recorded, or do you want to wait until that discussion happens?
I would like the meeting to be recorded unless there's objection from the board members or staff. All right, we'll work on the final policy when we have the further discussion. So that's my thought on that. Is that all right, Emmy?
Well, again, I'm not the decision maker. I'm just trying to make sure everybody's fully informed in how we proceed.
That's right, Emmy. I am the decision maker for the chair and our procedures. So what I would like to do then is go with our first presentation on our work in jail services, the Behavioral Health Board's work on that. And so I forgot who is actually going to make that presentation.
It's myself and Julie Presapora. So Julie, would you like to start? And then I can start sharing my screen after introductions.
Absolutely. So I am Julie Presapora. I'm the Assistant Director of Psychiatric Nursing. I am part of the chain of support for Sempervirens, our crisis stabilization unit, our behavioral health services at the jail, and also CCRC. And I just want to thank you. I'm very thankful for this opportunity to share with you the services that we provide to the clients at the jail. And also, I'm looking forward to answering any questions that the board may have or the public that is joining.
Thank you, Julie. I'm Kelly Johnson. As I mentioned earlier, I'm a senior program manager at Behavioral Health, and I oversee a number of programs, mostly forensics and crisis programs. So I oversee the jail behavioral health services, our Community Corrections Resource Center, which also includes the misdemeanor and competent caseload, our Mobile Intervention and Services Team MIST, which also includes mental health diversion, our Adults Mobile Response Team, and I'm also the Crisis Intervention Team or CIT coordinator for the county, and I oversee the DHHS side of the crisis negotiation team. And I've been working here for about 8 years, and I started as a clinician on the crisis stabilization unit and have worked in, I think, 11 programs at this point, either as direct service staff, supervisor, or manager over the more than 8 years I've been here. And I appreciate being here today. And I especially appreciate you moving the presentation up. I do have another meeting for diversion with Department of State Hospitals at 1 p.m. that I need to attend. So on that note, I'm going to go ahead and start sharing my screen. I please ask that people save questions for the end, since we do have only 20 minutes to present. And we should hopefully have time at the end to answer your questions. So just 1 second here. All right, so I'll go ahead and pass it over to Julie.
There are basic components to the services that we provide to our behavioral health patients. Screening and evaluation is one of the first components, treatment modalities. Also ensuring that they are being cared for by qualified mental health staff in sufficient numbers. Also inpatient hospitalization.
Legistar.
What?
Who said that? What?
She muted. It was.
Oh, okay. Thank you.
Looks like Supervisor Michelle Bushnell has joined us. She is an alternate for me on the Behavioral Health Board. Welcome,
Thank you.
Michelle.
Thank you, and that was me, you guys. I apologize. I wasn't on mute.
That's all right. We're glad to have you here. All right, we can proceed.
Also maintaining accurate mental health records and discharge planning.
All right, and we'll go into more detail about these things as we go throughout the presentation.
People with behavioral health disorders in the criminal justice system.
All right, so our goal is to support people with behavioral health disorders while they're in custody, to stabilize and to prevent further decompensation while they're in custody, and to provide appropriate treatment. We know that people with mental health disorders are especially vulnerable within custody, and we work very closely with the custody staff as well as WellPath, our medical provider, to meet the needs of our folks with mental health disorders within the Humboldt County Correctional Facility. We have several different options for people to divert them from the criminal justice system, not specifically just the mental health diversion program, but other programs to support people on release to access behavioral health services in the community to hopefully prevent reoffending and recidivism into the criminal justice system.
Screening and evaluation. All inmates are evaluated by a medical nurse when they are brought into custody. And during this medical screening, they are also screening for any prior behavioral health services and also current use of behavioral health medications. If a client does come into, sorry, somehow I got muted. So if a client does come into custody and they are on behavioral health medications, they do have a current prescription within 30 days. We continue their medications. If there's not a psychiatric prescriber currently in the jail at that time to continue their medications for 30 days, then what we do is we call Sempervirens. So we really are all connected. And any clients that come in with behavioral health services and also behavioral health medications are screened by the physician within 30 days.
The way that there's several ways that referrals can happen within the correctional facility. Inmates can refer, or correctional staff can refer, medical staff from WellPath can refer. And they have slips that inmates can fill out requesting behavioral health services. And we meet daily to triage those referrals. And we have a spreadsheet that we call the daily board, where we review each referral and assign a staff member to meet with them. And so typically what will happen is a behavioral health clinician will meet with the inmate and do a screening and determine what their needs are, and to complete what we call, it's a jail behavioral health assessment. It's called the 1031 form. It's a brief assessment, provides a diagnosis, and then they would be put on the schedule to see the psychiatrist and nursing staff if there is a behavioral health medication need.
Qualified behavioral health staff. We have amazing staff that are down at the jail that are qualified in behavioral health and that care for our clients in the jail. Currently, we have 2 psychiatrists and a nurse practitioner, a supervising clinician who you guys have just met, that's Kathy. There are 4 clinicians. Currently, there are 2 vacancies. There are 2 psychiatric nurses, a case manager, and also a substance abuse counselor.
So as you're all aware, we've had a staffing crisis throughout the county. It's not just our county. I think all counties are struggling with this, and probably all states. We have a shortage of qualified people applying for positions. We were fully staffed in the jail. I was very proud of that for a couple of months. And then unfortunately, we did have some additional staff move on to other positions, either within the organization or outside the organization. We have been able to provide 7-day-a-week staffing for several months now, which has been a great improvement. In the past, we were so short-staffed that we really didn't have the capacity to provide 7-day-a-week coverage. And so I'm really grateful that we're able to do that now. And we're actively recruiting to fill those vacant positions. In terms of the substance abuse counselor, I did just onboard a retired annuitant as an extra help employee this week. She's stationed at our Community Corrections Resource Center, but she will be providing some services in the jail as well. And then we're actively working on filling those 2 vacant clinician positions. As Julie mentioned, Cassie is our supervising clinician, and she's there all day, every day, Monday through Friday, and sometimes on weekends. And she really helps to fill that gap. She provides quite a bit of direct service to help fill that gap while we fill those vacant positions.
Treatment and modalities. Medication. When clients are prescribed medication, they are seen by the psychiatrist or the nurse practitioner before the medication is continued. They're also monitored. All patients are seen within 90 days that are prescribed medication, but it's also up to the prescriber when they feel it would be best to follow up. If the client is starting their medication, if they haven't been on the medication before, we do follow up sooner than that. Also, we have nursing staff. We have 2 nurses that are at the jail, which if clients, like Kelly had said, they can put in a slip to see a psychiatric provider. Most of the time, the nurses go to make sure that there's nothing we can do for an immediate need and if we can meet them. So our formulary at the jail contains a large range of psychiatric medications. We have access to all of the same medications that are stocked inside of our hospital. We have long-acting injections that we can dispense at the jail. And overall, emergency services and transfer to sempervirens. If a client's needs are too acute for behavioral health staff to manage, clients are transferred to sempervirens, and they are evaluated for an inpatient stay.
And typically the way that works is our behavioral health clinicians will assess for 5150 criteria, and we have a transfer process outlined for sempervirens. We try to bypass the emergency department if at all possible. We'll attempt to obtain a COVID test within the facility and complete some it's not a full medical clearance, but on the transfer form, there are some vital signs and basic medical items that need to be addressed prior to transfer. And at times the custody or the staff in the jail are not able to obtain the COVID swab. Then they would attempt to bring the individual to our main behavioral health site and have our behavioral health staff attempt to do the COVID swab. If that fails, then we do have to take them to the emergency department at St. Joe's to obtain that COVID swab. And then the person waits at the jail until we receive those negative test results, and then we coordinate the transfer to sempervirens. And there's a number of ways that we may initiate doing a 5150 assessment in custody. We have the safety cell, so if anybody is harming themselves or harming others, they may be placed in the safety cell, and behavioral health staff have up to 12 hours to assess that individual. We also receive calls from the housing officers asking for us to meet with certain individuals. And then also in processing, when people come in for booking and for a book and release, we may be asked to assess an individual prior to them being released. And so those are typically in the types of situations that we may be asked to assess somebody for 5150 criteria. But we also have clinicians and our other staff, the case manager, substance abuse counselor, nursing staff, meeting with individuals regularly. We don't provide ongoing traditional psychotherapy in the jail. It's mostly brief intervention and crisis intervention. But there are some individuals that are in custody that do need regular check-ins. And so the team, as I mentioned, when we meet daily to review the daily board and discuss cases, we talk about what the needs are of the individuals and come up with individualized plans to address people's needs. And Cassie, as the supervisor, often takes on some of the more challenging cases that need a more seasoned clinician, and she'll schedule weekly or more frequent as needed check-ins with specific individuals that need more intensive support while in custody. Julie, do you want me to take this one?
Yeah, that sounds great.
Okay. So there is a jail-based competency treatment program within our jail. It's been operating for about 15 months. We do not hold the contract for that program. It's managed by WellPath. So I can speak to it very briefly, but we don't oversee that program. Typically, if somebody has the doubt raised in terms of competency, there will be a court-appointed evaluator to do the competency evaluation. And if the person is deemed incompetent, we'll receive a copy of that report. And if it's a felony incompetent to stand trial case, we will have a medication evaluation done by one of our psychiatrists to determine whether or not they're going to qualify for an involuntary medication order. And we provide the medication support to that individual while they're waiting for placement in either the state hospital or the jail-based competency treatment program, or JBCT for short. So I will tell you that the wait list for the state hospital is incredibly long. It sometimes takes 6 months or longer to get people placed at the state hospital. JBCT has been doing amazing work, and it often shortens that length of stay for people so that we can help them obtain treatment and restore to competency sooner, so they're not just languishing in custody. And so once they're admitted to JBCT or transferred to the state hospital, then they're under the care of the Department of State Hospitals, and DHHS is no longer the treatment provider for that individual. Once they're restored to competency, then they'll come back to our care. And so we'll continue the medications until they leave custody. There are some challenges with that. There's different formularies between WellPath, the state hospital, and DHHS. And so there's definitely some challenges that come up at times. Also, if people aren't on an involuntary medication order, they may choose to stop taking their medications. And there are times where people decompensate and then become incompetent again. JBCT has 6 beds. They also accept referrals from Del Norte County. They have a clinician director through WellPath. That's currently a vacant position. They have a custody staff, a deputy that's assigned to JBCT, and she works there Monday through Friday. And then they have a part-time office assistant through WellPath. And then they also have telehealth psychiatrist and psychologist that meets with the JBCT participants for, they have 1 hour a week total for all 6 patients that they provide psychiatry via telehealth. It's a really great program. I know some of you have had the opportunity to tour the facility. And we also just last night around midnight, came back from Ventura County Jail. Cassie and I went down with Captain Christian and Lieutenant Griffin and our JBCT officer, Llewellyn. And we toured not only their JBCT program, but also they have this really progressive mental health unit within their jail. And we're looking at how we may be able to implement something like that in our county. It's still at the very beginning phases. We literally got back at midnight last night. So there's still some work to be done there, but some exciting things are hopefully on the horizon in terms of creating some mental health specific housing units within our correctional facility.
Discharge planning. Continuity of care is very important to us. We want to do everything we can to make sure that our mental health clients are successful. So as Kelly had already spoke about the classification meeting that happens every week, medications during their discharge planning are also addressed. We make sure that our clients have a 2-week supply of medications, a 14-day supply of their medications, and if they're not able to cover the 14 days of medications, then that is billed out to the expense of the county. Referral to specialty outpatient programs and the Community Corrections Resource Center. The Community Corrections Resource Center is just a wonderful program. We do have a psychiatric nurse that is embedded within the CCRC program. He's a case manager. So he is there if the client's, one of his main jobs at CCRC is really medication education and any type of education we can give to the clients to make sure that they're successful in taking their medications and not discontinuing them. So Gabe does go out with the case managers and also does long-acting injectables out in the field. So like I said, we truly are trying to make sure that we are making that our clients that are discharged have access to their medications and to try to break down any barriers that could possibly be there.
All right, so in addition to the classification meeting, we have our internal team meetings daily. Classification is a meeting that's run by custody staff, and it includes WellPath and behavioral health staff as well. We meet every other week with the whole group, and then the off weeks, it's just the JBCT folks and custody staff. In those meetings, we review anybody that's currently in custody that's been deemed incompetent to stand trial. as well as a variety of other, pardon me, I got distracted by a message on my phone. Any other special needs populations that we need to work together to make collaborative plans for while people are in custody. And so both Cassie and I attend that meeting, as well as we have our other line staff attend those meetings as well on a rotating basis. And it's a really great opportunity to just make sure that we're all on the same page and that we're working collaboratively within the jail. Our case manager works with inmates on supporting them with release planning. And so if somebody needs to be referred to a residential substance use disorder program or some other kind of program on release, or if they need support with accessing entitlements for when they are released, she works with them while they're in custody to support that plan. And anybody that's receiving medications in custody can be, if they're not already an active behavioral health client in our outpatient services, we'll do what we call a crosswalk to the Community Corrections Resource Center, or CCRC. It's literally only 2 blocks away at the corner of 4th and H Street. And so we'll have staff meet with them on release and walk them over to CCRC to meet with, we have a clinician, a case manager, a substance abuse counselor, and then, as Julie mentioned, a psychiatric nurse case manager housed at CCRC. And so they can get them open to outpatient behavioral health services and provide those continuity of care services until they can get open to ongoing services at the main behavioral health site at 720 Wood Street. We also have a contract with the Department of State Hospitals to provide mental health diversion services. I also manage that team. We have a supervising mental health clinician, a mental health clinician, a case manager, and a peer coach. And so when referrals are made for mental health diversion, we have a whole process that I don't have time to go into right now, where we will meet with the individual, evaluate for appropriateness, and then create a treatment plan and work on release planning. And then we provide ongoing intensive behavioral health services to them for the length of their diversion term. So all of those programs work really collaboratively together with our jail behavioral health team, but they are unique teams that are working in the community. And it helps that I manage all 3 of those programs. I'm able to help kind of streamline the process between those different programs to make sure that inmates' needs are being met on release. So that's the end. Oh, I'm sorry.
No, I'm glad to hear from you. I just want to move on to the presentation. It can be taken off the screen and you can give us the rest of your comments, okay?
Yes.
Okay, thank you.
So that's the end of our formal presentation. We don't have much time, but are there any questions?
So let me as the chair kind of manage that process. And I have a quick comment, is that people on the board and the community don't understand many of the abbreviations. So when you say CCRC, you know, we don't understand that. So we appreciate everyone on staff and all the presentations to clarify those things. I don't want to take you back on that, but
it was spelled out. It was Community Corrections Resource Center.
I know I saw it on the screen, but then CCRC was used frequently and I'm having trouble myself following all of that. So I just wanted to say that it helps us. So then I guess I would like to start, and I'll try to do an order of hands. I can't always do that, but I saw your hand, Madison, and then I see Laura's, and then I see Deborah. Madison.
Yeah, thank you. So I know you went over it kind of extensively about when an inmate or a person, I guess the intake process. And so my question is though, like, who's deemed the mental illness on an inmate? Is it the person, the police, or the jail? Because I have some personal experiences recently where the individual was like, I'm XYZ mental illness, and then trying to tell the police that, and then they also have, you know, like, I want to go into semper virens, and then instead of being sent to Semper Byron's, they're checked into the jail, held within for 4 to 6 hours, and then released back in, and then they're back in police custody 5 to 6 hours later, you know, because they're just kicked out. So you know, you said like that person can do the intake form and say, yes, you know, like I'm this, but I just know like certainly, you know, this individual was being a 5150 by a law enforcement agency, and then the second time wasn't. So I just think like a more streamlined, I guess, who is responsible for this inmate getting, you know, booked and or getting treatment.
Thank
We
you.
have, oh, go ahead, Kelly. So we have a great relationship with WellPath and also the housing officers and the sheriffs that are within the jail. So when somebody is brought into custody, the intake is completed by the medical nurse, and that's a very extensive intake. We talk about the medications that they are currently on. They get the collaborative information from previous days at WellPath. So their history is very extensively reviewed. If they are on a psychiatric medication, then that referral is immediately made to behavioral health. Then we validate their medications. We call the pharmacy to make sure that they have a current medication within 30 days. If they have that current medication within 30 days, then we immediately start that. We always have psychiatric prescribers that are available to us to do any type of consultations. If our psychiatric prescribers are not available in the jail at that moment, then we utilize the doctors on that scene.
And to answer,
oh, go ahead. Sorry, Kelly.
I think there was more to your question about the process that patrol has around whether or not they're taking somebody to jail or putting them on a 5150. Was that part of your question?
Let me redirect that. Madison, a follow-up question or statement?
Yeah, Kelly was kind of on the right path on that, but just from Julie on that follow-up was, you know, what if they're not on medication? You know, like what's the stamp for that? Like it's newly diagnosed, or, you know, or had a break, and, you know, they were maintaining, and then all of a sudden, you know, like a trauma event happened, and now this person is kind of off the hinges.
Right.
I'm just kind of confused because I've had this personal interaction with this individual last month and a half, and it's just kind of confusing. You know, this person wants help, but then they're not getting the help. And I understand there's like short staffing, lack of resources in our community. Our facility is taking on 4 other counties, you know, patients as well. And so just trying to streamline that.
So as I mentioned before, inmates can self-refer, custody staff can refer, medical staff can refer. We also keep an eye on people that we already know, and we'll sometimes self-initiate referrals ourselves. And also law enforcement or community members often call us to give us a heads up. Hey, I'm bringing this person into custody. I think you guys need to see them. And so then we'll put them on our daily board and identify a staff person that will meet with them. But in terms of your question about what happens before they even get to custody, peace officers are able to write 5150s in the state of California, and it's up to them to make that determination. Different law enforcement agencies have different thresholds in terms of when they'll place somebody on a 5150. It often gets complicated if a person has also committed a crime, or they're violent, or they're under the influence of substances, where it may not be clear if they're actually meeting 5150 criteria. And so in some cases, law enforcement chooses to book them into custody so that there's a period of time for observation. And a lot of times that does happen with book and releases, is somebody maybe, you know, have used a stimulant and is experiencing psychosis, and it may not be due to a mental health disorder, and it would be inappropriate to place them on a 5150 if it's not due to a mental health disorder. And so that's where our clinical staff come in terms of being able to make that assessment and to triage and to initiate that transfer to Semper Virens at that time. But I think it varies department to department in terms of how law enforcement are handling these issues.
I have a follow-up question. Do you guys collaborate with the tribes at all? I'm going to bring this up. I know it's a very sensitive topic, and I apologize beforehand. You know, the recent missing of Emily Risling, you know, she had a psychotic break, you know, was in the papers of all the situation, and now like she's missing, you know, was she
Yes.
was arrested
Absolutely.
and then happened, obviously. So, you know, that's just concerning. So like, how much are you working with, you know, tribal, you know, Department of Health Services, you know, could that situation have been avoided, you know?
Well, I can't speak to the specifics of an individual case, but I will say it's a huge passion of mine to build relationships with our tribal partners. We have a great working relationship with the Yurok tribe. And in fact, I just had our annual crisis intervention team, or CIT training, a few weeks ago. And the Yurok chief of police, Greg O'Rourke, was a huge part of that. And they sent several officers as well as Yurok tribal court staff to the training, and we work very closely. We also work really closely with the Hoopa tribe. And so a lot of times what happens is I end up being the contact, and they call me and say, hey, I have this person, I need help, what should I do? And we sort of coordinate together. It varies tribe to tribe in terms of what level of collaboration we have, but it is definitely something that I've worked hard on. I've only been managing the jail for about a year, but I've been involved in crisis services and coordinating CIT for a long time. And so I've been working really diligently to solidify those relationships. I'm happy to give you my phone number. If there's specific people that you'd like me to talk to, I'm always happy to connect with people and figure out how we can improve those relationships.
Yeah, absolutely. I think that'd be great. I appreciate that. I think your email might be on the.
It is. And I'll
Okay.
put my work cell phone number in the chat.
Okay. Thank you, Kelly.
Thank you, Madison. Let's move on to some other hands. And the next hand I saw was Laura Montañez. That question still with you, or comment?
I have so many questions, and I know that you have to go at 1, Kelly, and so I feel like I need more time. I'll just ask a couple of them. When someone's on medication and they're released, do they get meds for like 30 days?
I'll let Julie respond to that.
So the supply is for a 14 days of medication, and that's covered at county expense.
So they're given them?
And then, correct. So we call that into the pharmacy. We normally use CVS. So they receive the 14 days of medication, and Kelly had talked about crosswalking clients. Sometimes we even take the clients to the pharmacy to pick up their medications. And then we try everything that we can to make sure that they see a provider within the 14 days. Sometimes clients aren't able to get to a provider within 14 days. So we look at those cases, and most of the times we give them another 2-week supply at county expense until their Medi-Cal is kicked back in to cover the cost of their meds.
Okay,
And that was
go ahead, sorry.
That was the part I was saying, that they get crosswalked to the Community Corrections Resource Center, or CCRC, and we get them in to see our psychiatrists there until we can get them transitioned to ongoing behavioral health services elsewhere.
Follow-up question, Laura. Or the next question.
They're not handed medication. They have to go pick up a prescription.
Correct.
Yes. And we have staff that can assist them with that if needed. That's part of the crosswalking process I mentioned, where we'll have a staff person meet them on release. And if they need that level of support. We don't have the capacity to do that for everyone, but if there's somebody that's going to need ongoing behavioral health services, we would have a case manager or somebody meet with them on release, take them to the pharmacy, take them to the Community Corrections Resource Center for that behavioral health assessment so that they can get their ongoing care.
Okay, so when that doesn't happen, that's just, I see all too often that people don't get their meds, and they don't have a phone, they don't have any transportation, they're living on the street. And so that seems like a gap. And I know there are some counties where they actually give meds. So that's something I think I might want to start an ad hoc committee, because there's a lot of places I think we can help people.
So one place to start, we're not licensed to be a dispensary or a pharmacy. at the jail because we're an outpatient clinic. So we don't have a supply of medications that we can provide to the client when they're discharging. So we're unable to give them the medications when they leave, but we ensure that there is a prescription called in and they know where to pick up their medications and how to pick up their medications on discharge.
They also have the right to refuse. And so many times we'll have staff meet with them on release and they decline the support. And so we can't force them to go with us if they don't want to.
Okay, so this is a big question, but patients with anosognosia, patients who don't understand that they have an illness. And I don't expect anybody to answer that now. It's just a follow-up question. I spent a lot of time in the jail and it just seems like you're doing good work and we could do a lot more. And that's what I would like to try to support.
I would encourage you to advocate at the state level because the laws are very restrictive in terms of forced treatment. And so we are very limited in what we can do legally in terms of forcing people to take medications.
Yeah, I have so much more, but go ahead.
It's a very big subject and I appreciate the presentations and the work. I'd like to go to the next hand. I saw that. Was that you, Debbie?
Yeah, I just had a simple question, which how many people are you working with at any given time in the correctional facility? And about what percent of inmates, do you know, are needing mental health services?
That's a good question. I don't have the specific percentages in front of me.
General numbers. Just, I mean, like
so
how
the general census right now is around 275, which is reduced capacity from about 400. We do have a monthly dashboard that we where we quantify the number of patients that we're seeing. I don't have it up in front of me, but I can get that information for you if you would like. I can ask Joe to send it out at a later date.
Yeah, I think that would be good to know. Thank you.
Great.
Thank you very much. Is there another hand, another question or comment from the board?
Couple.
Yes, Tim. And then Allison.
Okay, the first one just sort of a short question, then I have more of a comment, but and actually before I do that, I would just say, Laura, that one positive thing that's going on now is the county's working on an AOT program, and that may help some of the people who have anosognosia. It's not a mandatory program in terms of the medication, but people seem to react well to it. So that's something on the horizon that's positive. But the question for Kelly, the contract with DSH for diversion, is that actually diversion or is it a competency restoration, a pre-trial program?
It's for mental health diversion. It has very specific criteria that's more narrow than the PC 1001.36 diversion track. It must be a felony charge, and currently they must have one of 3 diagnoses, either schizophrenia, schizoaffective disorder, or bipolar 1 disorder, and they have to be already incompetent to stand trial or at risk of being incompetent, and they can't have already received restoration services on the current charges. There are some expansion dollars coming down the pike. Unfortunately, in our community, we haven't had a very good track record in addressing when people aren't following the terms of their diversion. And so we're expecting a corrective action from the Department of State Hospitals, and we may not be eligible for expansion dollars. And part of that's because we're not remanding people to custody when they violate the terms of their diversion. And so it's creating a public safety risk. And so we meet regularly with our justice partners to try to mitigate those issues so that we can be eligible for those expansion dollars. And if we get those expansion dollars, that will open up the diagnostic criteria for the diversion program. And we do at times accept the regular track 1 PC 1001.36 diversion referrals, but unfortunately due to staffing and budget constraints, We don't receive any funding to serve that population, and we don't have the capacity to accept those referrals at this time. And so we only accept referrals that qualify for the DSH contract dollars.
So those first, the ones you mentioned, are those misdemeanors?
They can be. It could be misdemeanor or felony for PC 1001.36.
Okay, thanks. I guess then the final thing, I just kind of a comment. You had mentioned that that the county was kind of out of the loop. You didn't say it that way, but we're not responsible for the JBCT folks who were being treated by WellPath with funding from DSH. Is that, I mean, is that accurate representation of what you're saying?
Yes. So when somebody is admitted to the jail-based competency treatment program, or JBCT, they're technically a DSH patient because DSH funds the jail-based competency treatment program. And so at that point, they're under the care of WellPath under DSH, if that makes sense.
Does DSH provide any on-site oversight of the of what's going on in the jail?
I don't know the answer to that question. That would be a great question for WellPath.
Okay. The reason I say that, I'm just a little concerned that when our folks switch over, which I think is great that they're moving over into that facility, but it'd be nice. There are family members, our community members, that if we kind of knew what was going on, because you've got a for-profit entity that's treating them with oversight that at least I don't know, and it's just a little concerning. It would be nice if there was some type of oversight, even if there was no direction allowed.
I believe there is oversight. They're in constant communication with DSH. I just don't oversee that program, so I don't know the specifics of it. So I don't want to speak on behalf of WellPath.
So I guess the last thing is that we have a lot of interest in questions here. I'm just wondering if maybe we could compile those questions and just get them to you folks, and just have a written response, and then see where it goes from there. I know Laura mentioned an ad hoc, but I know I've got about 15 and I just no time to get into them.
Sure. And Tim, you know how to reach me, and I'll put my email in the chat. If there's anybody else that wants to reach out to me directly, you're welcome to. And I also just wanted to go back to the question earlier about the number of patients that we're seeing from Deborah. Thank you, Cassie, for sending me these numbers. So for October, we had 105 clients on psychiatric medications with 161 psychiatrist visits. 261 clients received visits from mental health clinicians, and we had 50 new clients and 211 ongoing clients just in the month of October.
Great, thanks.
All right. Any more follow-up? You ready to pass it on to another question, comment, Mr. Ash?
No, I'm done.
Okay.
And just thank you, Kelly. And I was also really glad to hear that you guys went down to Ventura. I mean, our jail is a de facto mental health facility, and having it be more designed and managed for that is really a step forward if we can pull it off. And I hope if you need support from the Board of Supervisors, that we can get it.
Thank you.
Thank you, Tim. I see Allison. You have a hand up, comments, questions?
I do. Great presentation, Kelly. Thank you. I just have a question. I'm wondering how many are on the wait list for state hospitals currently? And I believe you said there are 6 beds with JBCT. Are there more than that on the wait list that are needing?
Oh yeah. Cassie, do you happen to have one second. I should have had my classification notes in front of me, and I don't, but
that's
Cassie
okay.
will tell me momentarily.
And the wait is 6 months or longer, correct?
It depends. It depends. It's interesting because Ventura told us it only takes them a month So I'm not sure why it's so hard for Humboldt, but that was interesting news.
That is interesting.
Lawsuits help.
Yeah.
Do you know which state hospital they're transferred to out of here, or they're just a number that they would go to?
I can
Go
speak
ahead,
to that.
Kathy. Yeah.
Sorry. So we have 15 clients who are currently waiting, who've been deemed incompetent and are waiting to go to the state hospital. We have 7 people on the JBCP wait list, the Competency Restoration Program here. And we have 8 clients that are in the process of being deemed incompetent. So they're somewhere in that court process. And for the state hospital, it depends on, once somebody's deemed incompetent, the referral is sent to the head of the state hospitals and they deem which hospital. So we don't have any say in that.
Thank you.
I could add something. This is Dr. Wilson, because I've done such referrals from Del Norte County Jail. And there is a mechanism for getting people expedited if they're in a psychiatric emergency. And it requires calling the medical director, who is Dr. Catherine Warburton, and explaining the situation. And in that case, they expedite people if they're in a psychiatric emergency. I'm going to go on mute.
Okay, thank you. Yeah, I see your hand and we'll get to that. Maybe that was it. So Allison, you ready to pass it on to some other question?
I am, yes, thank you.
I saw Isabella wave a hand. Would you like a question or comment at this time?
Yes, hello, everybody. I wanted to thank you for the brush up, especially given, you know, in my personal professional capacity, oftentimes, you know, when I initially am referred clients, they are in custody. So connecting them with mental health services, I wanted to make a quick note on that. It is quite often that clients do not self-report, at least the population that I serve. And I have enjoyed a pretty flourishing relationship with jail mental health in the sense that I will directly as a provider call and make my own referral on behalf of individuals who are currently in custody. So I wanted to relay that to Miss Flynn Madison. That is something that I do very often and have extreme success with, and that usually just entails a phone call and or an email. And that's a great way to get clients connected to services. And then my question was, what with regards to the crosswalking, you know, once again, I know it's offered, but my people will oftentimes deny that service. And so I end up kind of coming in and being a crosswalker myself. So I wanted to know more about what statistics we had with regards to like how often that's done by staff, or, you know, what your denial rate is. Just for my own curiosity and streamlining efforts too, because that is also something that happens often with the population that I serve. You know, they are given those prescriptions, but there is no follow-up to the pharmacy.
Yeah, it's not data that we're collecting, and so I don't have specific numbers. I don't know, Cassie, if anecdotally, do you have a response for that?
I mean, I think that's something that we're always working to improve, because I think lack of insight, and it's not something we can force someone to follow up with. But I always, any client that I'm working with, I am 90% of the time give them my card and my cell phone number, and they are welcome to call me at any time if they need help. So I have clients in different prisons that I'm helping connect to services, even when they're not in our jail, or clients who are texting me in the middle of the night to get services. And you know, the clients that I'm very concerned about that I want to talk to before they get discharged, I'll put what we call a mental health detainer on them. And the jail will usually hold that client until a mental health clinician can talk with them, at least trying to encourage them. I sometimes also use peers from my other program, the mobile response team, to do some follow-up if they have the capacity. Staffing is an issue. I would love 2 more case managers for that service.
I was thinking the same, yeah. So, Isabella, you ready to pass questions and comments on? Thank you very much. I want to
Thank
go
you.
with, yeah, I want to go with Dr. Wilson. Then I see your hand up again, Mr. Ash. So, Dr. Wilson, a comment, question?
Yes, thank you so much. I think that one of the things that I try to kind of bring forward in all of the different venues that I can is the idea that whether or not patients who have anosognosia are involved with the criminal justice system or not, they are the responsibility of our Department of Health and Human Services behavioral health branch to take care of. So when it's discussed things like, well, they don't qualify for this or that. Okay, well, they're not all going to be able to be an AOT or on the crisis res unit. You know, there's probably 150 or 200 patients that are struggling with treatment-resistant illness and anosognosia and substance dependence who are, for some reason, not thought to be the responsibility of our county mental health system. So I try to throw that out because these are the patients that are near and dear to my heart. These are the patients that when I was the psychiatrist at the jail, I was the only psychiatrist who ever saw them because they would never follow up when they got out. And you can probably hear the emotion in my voice because there's been a number of bad things that have happened in our community that could have been prevented if they were getting the right amount of treatment. So I'll get off now and just be on mute, but I thank you very much for the opportunity to express my opinion publicly.
Thank you, Dr. Wilson. Tim Ash, another comment, question?
Yeah, I just wanted to follow up on the issue of the weights in the jail for the state hospital. In addition to what Dr. Wilson said about, you can, say, hey, this is emergency. I would kind of offer up that really doesn't happen as much as it should, because a lot of times the people are waiting to go to the state hospital, and jail may be refusing medication, may not have a mandatory medication, and they're psychotic, and that's like having a stroke. They're being damaged as they sit there. So those are quiet emergencies. But
yeah. Tim, what we do in those cases is write what's called an acuity letter. And so we work collaboratively with custody staff and our psychiatrists to write a letter to the state hospital advocating that they accept them sooner. And in our experience, I think it's about a 50% success rate that it has any impact, unfortunately.
Yeah,
but Ventura County's said that they have almost 100% success rate, and they're going to share with us an example of their acuity letters, so maybe we can improve ours to be more effective.
Yeah, it's just there's a lot of things that can help, and I would guess that it's not your letter. There's other factors involved, but one thing that happens is if a person's sitting in the jail long enough, at some point, and I think the judges probably have a little unofficial number there, when they've ordered someone in the hospital but they're not there, they will call the state hospitals to the court and ask them to explain themselves at the penalty of legal penalties if they don't show. So they do show, and mysteriously beds open up at that point. And then the final,
there is that new, I'm not sure if I'm using the right word, somebody else could probably speak to it better than me, but there's some sort of legislation or sanction or something happening with the state hospital, or they're expected to accept people within 28 days. Does somebody else know about that?
What I do know is that you can call Dr. Catherine Warburton directly. She's the medical director of the Department of State Hospitals, and she's based in Napa. So that's,
I don't know who's
recommend that.
Is that you,
That's
Dr.
Wilson? Yeah.
Okay. Thank you.
But the last thing, what I found out a couple of years ago was that I spoke to the deputy director at DSH, and what I was told was that several counties around the state have sued DSH, and when they have these people languishing in the jail for months and months. So they sued them, and those counties are at the top of the list for getting people admitted. That's a reality. So, you know, the JBCT is basically was DSH's response to that. That was their solution.
All right, thank you. I'm mindful of our agenda. This has been a great presentation, asking and sharing and other things that in my mind, I keep thinking, oh, staff, you know, and that's part of the challenge. And while you guys are doing a great job, that's one of those challenges that we just faced. So are there any other comments or questions? Again, I want to thank you. Thank you very much, Kelly and Julie and Cassie for being with us and making that presentation.
Thank you. I'm going to leave for my other meeting now.
I know you. Thanks for coming and staying that long. Thank you.
No problem. Take care.
Thank you.
Thank you. So this, it's interesting. We probably should have done this first, but public comments, and we are an open meeting to the public and invite people to come and participate primarily with their comments. And we have a time set aside for any general comments to be made from the public, and we're wanting you to particularly focus on matters of behavioral health, the board and the department. But everyone is allowed to speak. And at this time also, I want to say, we make that open for special presentations as well. We want you to be involved with that. So are there any other questions, comments from the public? All right, this is one of the few. Yes.
This is Sonia with HCTC. I do have a public comment to make.
Okay.
Tim Ash called me, I think last week, kind of exploring the K-aged youth seats on the board, and wanted to just follow up in a public comment. I checked in with staff and youth around this, and HCTC feels pretty passionately about keeping 2 seats set aside for K youth. And then I also would like to make a formal request that it gets put into the bylaws. It seemed like when Tim researched it, it was an informal agreement, but I would like to see it formally put in the Behavioral Health Board bylaws that there are 2 seats on the board left for K-aged youth. And if those seats can't be filled by specifically maybe youth advocacy board members through HCTC, that there's lots of other youth serving agencies within the county that could be looked at for youth that might be interested in serving those positions.
Thank you very much. The valuable requests and comments.
And then I had another question, and it may not be able to be answered, but I just was wondering what the process was, or formal process, in getting material sent to the board, if there's an approval process that goes through administration, or if there's a way that material specifically like from our youth advocacy board can be sent to the board, and what that process is.
Yes, there is one. You sent that information to Joe McManus, and as our administrative assistant, our secretary, and then he refers that to me. And then if I need to go to the executive committee. So we want to expedite that. There's a lot of information we send out, but that's kind of the formal process. All right, thank you very much. I don't know if you wanted a follow-up comment or question on that, Sonia?
No, I think that's it. Just making a request that the TAE board seats get put into the bylaws, and you answer my other question. Thank you.
Thank you very much. So I'd like to move on to our agenda. We have communications, and this is a standing item from the members of the board who want to share things that are on their heart or things that they're working on. So I'll just open to this. If you're on the board and you want to share something, please raise your hand. All right. Then hearing nothing, then we'll move on. We have these action items. They're pretty straightforward. The first one is the approval of our minutes from our last meeting. I'm assuming everybody read them. and ready to vote on this. And I'll entertain a motion to approve them. We can have discussion after that.
I make a motion. Oh, sorry.
Everybody wants to make the motion. Okay, so any questions? Often in the procedure, you make the motion, then you talk about, do I have any questions or comments about it? Hearing none, then I'll approve. You can say aye or raise your hand.
Aye.
Aye.
All right, thank you. It works so much better in person, that's the whole thing. So, but that may be off for an indefinite period of time. So then the other one is I brought this up as sharing from my report that we have dues that are requested from us, $800, and it goes to, and you can see that on item B, the California Association of Local Behavioral Health Boards and Commissions. It's a wonderful site that provide training and things like that. And so I'm open to a vote, yay or nay, what you want to do about it.
I'll make a motion that we continue to be members and pay our dues.
I'll second that. This is Allison. Thank you.
Hi, Allison. Thank you very much. Any more comments or questions? Not everybody knows about this, but we've done it regularly and it's important. So hearing no other comments or questions, all in favor of this, say aye and raise your hand.
Aye.
Aye.
Okay.
Hey, Tim, before we move on, I just for the newer folks on the board, I don't recall the address, a URL for this site, but I would definitely recommend you guys look at it. It's got a lot of good information about behavioral health boards.
Right, it does. Training, best practices, all those kinds of things. Yeah. Lauren, did you nod your head? Go beyond nodding your head. Nodding your head was fine. Okay, so then, so the discussion item is we traditionally never have a meeting in December, being on the 3rd or 4th, and so that's our procedure. The questions or comments, that's kind of a normal thing. Do we need to vote on this, Mr. Ash?
No, we do not.
Okay. So any comments or questions about not having a meeting in December? All right, then our next, Madison, your hand is up.
That was just in for the agreements for the dues.
Okay. Okay, thanks. Thanks. All right, so that's then been ordered. We'll move along, and then we have any report from Connie, the DHHS director.
She's not here anymore.
Okay, then we'll move on to you.
Right. And I actually will say one thing that she could have shared if she were here, because it connects with something I wanted to share, which is related to the continued racial and cultural equity work that we're doing in behavioral health and at DHHS. They recently got approval to hire for DHHS a racial equity program manager, which is really great. And so we in behavioral health are also continuing to do that work and really linking with the broader DHHS work. There's a racial equity steering committee within DHHS, and then we within behavioral health have developed, I think I've referenced this already, a number of policies and processes to align with the work that's happening at the broader DHHS level. So I like saying that whenever I get an opportunity, because I'm really glad that we're committed to doing that work at all levels. A couple other things I just wanted to mention, and I see that I think all three of the deputies are on, so they can either add to or answer questions for any of these. One is we completed our annual EQRO last week, and I think it went fairly well. So you'll get to hear more about that as we get more information back on how that went. You got to meet Philippa, who I'm so glad to have on board. She's the hospital administrator, so that's a really big success for us to have that position filled with her. We have made some progress on the AOT RFP, and I think that's next on the agenda as an update. So I'll let Jack share additional information about that specifically. And then if there's anything else that either Paul, Jeremy, or Jack, you guys want to add in here, I think you could certainly do that.
I'm not sure if recently we were awarded the CCMU grant.
Oh, yeah.
That's just under $1 million over a 4-year period, 3-year period. And that is an infrastructure grant award to help support our mobile crisis services. So some of those funds are going to go towards paying for existing staff, as well as some training and equipment, including a couple SUVs. So we're pretty excited about that.
So quick question, Paul, does that mean that we might have video conference capabilities with that infrastructure money?
We have that currently, and we have that in use currently.
Oh, in the professional building, the conference room there?
Oh, do you mean
This is
like
different funding? This funding is specifically for mobile response crisis services, not necessarily for administrative infrastructure.
It's just a comment that I have on is that the future will mean people joining in person from a Zoom, and so needing better structure, conferencing room. And I've had said that, and so if you said in the future, that's fine. Anything else, Emmy?
Not for me, maybe Jeremy or Jack, I don't know.
Jeremy, you're unmuted.
Sure, I was just going to give an update. I know we had mentioned it here that we had also received a grant from the California Health Facility Financing Authority for a Children's Crisis Residential and Children's Crisis Stabilization Unit. And that is continuing to slowly move forward. We did finally get our contract agreement from the state that's been signed and executed. That went to the Board of Supervisors just recently. And so we're in the process now of getting all of the paperwork together to get the actual initial disbursement of funds. And then if we can get those funds released to us fairly soon, Dr. Buxbaum and his group is hoping to purchase a property sometime in December is the goal. So they have a site that they have an offer in. So they're hoping to close escrow. As soon as that all gets finalized and becomes official, we can share more information. But it's exciting that it's inching forward slowly. Once the property is actually purchased, there will have to be some construction and some renovation done to the property before it's able to be up and running. We'll also have to do a lot of licensing and certification for them to be able to bill Medi-Cal. So unfortunately, it's still quite a ways out before they'll be up and running to provide services, but we are making progress on that. So just wanted to give an update there.
Well, thank you, Jeremy. That's really important for many of us to know. I know among NAMI and other people, when will we have something like that for minors? And so, yeah, you can keep us updated on that. I do understand it's a long-term process. Thanks for working on that. So, then many of these things fall within the category of the Director of Behavioral Health Board Services. And so I sense that we're ready to move on unless there's someone else.
Before we do, I just had a follow-up for Jeremy.
Yes.
Yeah, and Jeremy, this really is great news. The one question that I've had, and I think you may have answered a little bit, but I don't understand, like you mentioned CSU. And so where does the CSU fit in terms of legal holds, that sort of thing at this facility, if at all?
So my understanding with this is that with this grant, what the goal is that as we purchase a facility, the vision is to have 3 beds that are crisis stabilization beds. So youth that are needing that level of care for that 23 hours, they can go there and get that intensive crisis stabilization services. And then if they need services beyond that, then they can transition into the crisis residential portion of the program, which crisis residential ends up being typically 2 weeks to maybe up to 30 days. So having it all in one site really is the advantage of this grant proposal. so that it would be a total of 9 crisis residential beds and 3 crisis stabilization beds. And staff that cover both of those through the provider. So I'm not sure if I answered your question directly, but
I think you did on the CSU part, but I didn't ask the second part is, are they on a hold when they move out of the CSU into the crisis residential?
No, crisis residential is not a hold situation. So it would just be, as long as they meet the medical necessity for that level of service, it's what's considered a daily rate for Medi-Cal. So as long as the provider documents that they need that level of service, then they're able to access that. So, but there's no legal hold. So it's basically a lower level service than a 5150 hold.
Okay, so they wouldn't be meeting. How about if they meet criteria and they're in the CSU? And they're 23 hours.
If they continue to need that level of service, and we probably still have to be looking at hospitalization, which would be out of the county. The hope is that through that CSU service that they can be stepped down to the crisis residential and really avoid the hospitalization. But that would still be the option if they need longer than that 23 hours of crisis stabilization.
Okay, great. I just wanted to really understand what the facility would be, but that's great. That's awesome.
Yeah. Thank you, Jeremy. It's another one of the good news for our work here. So, anyone else from Emmy's direct staff? I don't know what they're calling it, deputy directors, I guess. Thank you, Emmy. Thank you, everyone. We'll move on to the next item. That would be C and 9C, and that would be update on AOT. Jack.
Yes, thank you. So moving along on this one as well, we did get in 2 proposals for our request for proposal for assisted outpatient treatment, and the selection committee will be meeting tomorrow to review those 2 proposals and hopefully select one. And then, then that would be the one we go with and present it to the Board of Supervisors at some point. And so we'll hopefully tomorrow's meeting is a good and productive and fruitful one.
So yeah, I do too. I'm wondering what you think might be the next step after the selection in terms of presentations to the Behavioral Health Board, or what time, what you think would be helpful.
I think probably by the next meeting, it's in January, right? That we're meeting again. Yeah, probably by that time we can kind of go over the proposal that we've selected and maybe perhaps invite somebody from that agency to be here.
I do think that we're required, once we select a proposal, to then get it approved by the Board of Supervisors before we move forward with it more publicly. So that timing would also factor in.
Then we can talk about this at the executive meeting. Then this material should be sent out to the behavior so that we can work as our advisory committee with the Board of Supervisors to talk about that timeline. And we may need a larger time for the presentation of the report, but before that, and I understand the timeline is challenging. Emmy or Jack, kind of understand what I'm asking for?
I don't.
You're asking for a presentation on the AOT program?
Can we act formally as a Behavioral Health Board to examine the documents and send our advice to the Board of Supervisors?
Well, I think that we have a representative from the Behavioral Health Board on the selection committee. And so then the selection committee with broad representation will make a selection and then take that to the Board of Supervisors. I think certainly at that point, if, once the Board of Supervisors approves, I think that the Behavioral Health Board could, you know, share their thoughts about it. But I don't know that it doesn't get approved by the Behavioral Health Board before it goes to the Board of Supervisors.
Okay, so we just need the information. If we vote to write a letter or something like that, that would be in the process, but we're not going to vote to approve it. I understand that. I appreciate that. So back to the question of maybe in January, having a little lengthier time to present the proposal and discuss it so that we can understand it better. Does that make sense, Jack?
Mm-hmm. Yeah.
Okay.
Going to the Board of Supervisors.
When is it going?
Yeah.
I'm not sure. So it'll all be dependent on if we select someone on Friday, and then we just have to go through our internal process of, you know, preparing an agenda item and getting placed on the board's agenda and pulling together whatever documents are required. So
Do you
I
have
mean,
to negotiate?
Pardon me?
Do you have to negotiate a contract prior to going to the board?
I believe we go and get approval and then we negotiate the contract. And our intent is to have services in place in January. So we have ourselves under a fairly tight time frame. We've committed to trying to have AOT services in place in January.
All right, it's nice to know that. As I say, I want this on the regular agenda, and any more of those details we can work at executive committee. But thank you, Mr. Ash. Those are good questions. Anything else on the AOT agenda item? Questions? Mr. Ash, you're muted.
Yeah, I'm just wondering what has happened so far in terms of collaborating with the various stakeholders in the courts and DA, public defender, in that, in terms of developing the program. What contacts have happened so far?
Well, we have representation from the public defender's office and the jail and probation on the selection committee. We did do some outreach to the courts, but we probably just the timing of it wasn't right to get a representative from the judiciary on our selection committee.
And as you know, we have Behavioral Health Board and NAMI representation.
Right.
So once a provider is selected, then they will need to participate in the development of the program with us and with whatever stakeholders we deem necessary to include. So that's where I think that collaboration, more collaborative part would start.
Okay, well, that makes total sense if they would be part of that process. I just wondered in terms of the time frame of having a January provision of, starting up the program. It seems to me there'd be some overhead startup with getting all those people on board and having procedures and just having kind of an agreement in hand as far as how the whole thing was going to work, which is takes a little doing.
I'll say too that the two proposals that we received, both of those agencies have prior experience running an AOT program in their respective counties. So I think there's some baseline that they have, but for sure, as Emmy said, that sort of development piece I think will be really important once we select the proposal.
All right. Thank you. Any more comments or questions on the AOT report? Thank you very much, and thank you for the hard work you're putting into this, Jack. Thank you. So our next item is the Sud Dr Committee, and I want to start this by saying there was a miscommunication from my part. I just affirmed that Laura Montagna was the new chair, and then she called me back and said I didn't agree to that, and it wasn't what I was thinking about. So then what that means is that we don't have a chair of that yet. And Alyssa, we spoke about that, and so if there's anything either one of you want to say about the Sud CR committee, Alyssa, I'd ask you first. Hey, you got your Cosmos.
Still in the office and somebody else is talking right now, and so I was not eager to talk with my worker talking in the next.
Okay. All right, thank you. Laura?
Well, I had thought that Alyssa was the chair of that, and I had just stepped in to help originally. So if she does not want to be the chair of that, I didn't mean to take it away from her, is what I'm saying. That was her.
Okay, then I just have to talk even though my neighbor's talking, so please excuse that, everybody. So what happened was we had our first meeting. It went incredibly well, but we had to look at the rules for who could be chair because there was someone who was a participant from the community who actually wanted to be the chair. So I printed out those rules and I was going to take those rules back, confer with everyone. Last meeting did not happen. So instead of being able to discuss those rules and come up with, who wanted to be chair and who wanted to be second, we have had to wait on that until the next meeting where we can have that discussion. So where we're at is it has not been decided. The rules do not state that a board member has to be chair, not of, I think, subcommittees. That's just not a thing that we have to do that way. So it's all quite up in the air. If I end up being chair, that's perfectly fine. But the thing is if there is a very eager peer community member who also wishes to participate in that capacity and can be present, then, I want to be open to that happening. I don't want to, push them out of the way and take that role. So I am taking the position of waiting until we all get together to be able to discuss it again. I don't know. How does everybody feel about that?
Sounds fine to me. Sounds like the best way to go. Mr. Ash.
Yeah, I was just gonna say that one possibility, and I'm not sure I really understand all what's going on, but is just have a co-chair and you know what I mean? And then just kind of turn it over to the person who wants to be most active.
Yeah, that's what I was also waiting to see also was who actually showed up to the next meeting.
Okay.
we're still developing. I don't, it's like it was hilarious. Last meeting I was sick and I was still gonna show up sick, and then like 5 other people responded to the invite with they couldn't show up, and I was like, never mind, I'm sick, I'm not showing up. So it pretty much, I don't even know if it even happened.
So let me say this, and I've spoken to you about this, is that in the procedures and the bylaws, I appoint chairs of committees. I want to appoint anyone you think is the best one, okay? And I like the idea of a co-chair or an interim chair or whatever you want to say it, so that we have some formality. We can shift it and change it, but I sure appreciate what you're doing in there, Alyssa.
Yeah, we'll see where it goes. It's still getting off the ground. I think the fact that it hasn't been going for a long time has gotten a little bit in its way, but it's gonna happen. Well, we gotta just hang in there.
Yep, you do. Okay. Thank you very much. So the last item on the agenda is reports from me. I don't have a lot here. I guess one of the things, I have 2 things I just want to say is thank you so much for the new members. And I think I've said to you in interviews and things like that, it just takes a while to get to know how the board works. And the fact that you're showing up and asking questions and reading things is just wonderful. But that kind of a thing is you hang in there and you get to know us better, and that would be great. Again, glad to have you with us. The other thing is just kind of interesting to me. Steve Madrone put on the chat that he had to leave, and then he handed his role over to Michelle as the alternate. And so you got that chat, right, Michelle?
I did, yes.
Okay, so I think that means you can vote. Usually that's kind of for a whole meeting, but in the middle of a meeting, I've never had that experience before. But I do want to say to everybody, it seems to me at that point, you're a voting member. You are the representative from the Board of Soups. Does that make sense to you?
It does make sense. However, I don't know that I have voting power as the alternate.
Well, I think that's up to either our bylaws or to the Board of Soups. Tim, Ash, you're nodding your head.
For sure, but I'm pretty sure you can vote, Michelle.
Okay.
That was my thought on it, so we can double check it. But welcome. I'm so glad that you're here with us, and like anyone else, you're learning how we move ahead. And for all the new people, I just thought this was another great meeting. I think the staff for all that you're doing, and you're keeping us informed and presentations.
Hey Tim,
yeah.
Before you close it up, can I ask a question?
Sure.
Two things actually. The first one, could we get a copy of a list of board members with contact info?
Yes.
We've had those in the past, but I think it might be helpful for people if they're putting together committees or ad hocs or whatever.
That makes a lot of sense. Joe, you've done that before. You can put that together for us?
Sure.
And then send it out to us. And remember, it goes out to everyone. It's a public information, but that would be very helpful. Thank you. Good idea, Mr. Ash. Something else.
And then the second thing, Emmy, if you could update us on the bylaw situation.
Well, so the bylaws are starting over now. So I'm going to just need to take some time to be able to review again and to send to county council. I am thinking that you and Tim should give what you think is your final, now again, revised suggestion, because what you gave us included a lot of, we could do this or we could do that. Maybe this, it doesn't really matter that much to me. And so the two of you need to do some decision making about which of those things you want carried forward.
Mr. Ash, we have to solve some of our ambiguities and come up with some decisions. I think we're not the best to do that. With two Tims, it doesn't mean you get twice as much work done. So
no, in my comments, I was just trying to make the comment more food for thought. But if you want to, this is what we think, we can give you that.
Well, I mean, there are some things that I think you want to really have addressed, and some things that you have said, this is food for thought. We could do this one way or the other. But I do think that those ambiguities need to be your decision prior to me moving it forward to county council again, because we have already had it fully reviewed and approved. And so if we're going to go back again, I'd rather have that part kind of shored up and sorted out a little bit better.
Okay, I guess the only question in my mind is this a BHB decision, or is this something that Tim and I can informally put together, you know, kind of compile it all and give you direct, this is what we think. That makes sense?
I think jumping in, we have to approve them. After county is done with it, it's our bylaws and we have to vote on it. Is that what you're understanding?
Well, so behavioral health board would get whatever final version is back and you would approve, and then it would go to board of supervisors for their approval.
Yeah, okay. The board of supervisors approves it, but we have input.
Yeah, and you guys have asked for county council input on a number of things, and so we have had them review, but now there's some additional changes that you're suggesting or contemplating, and so that just needs to be firmed up before I send it back to county council again.
Thank you very much. I see a hand up from Allison.
I would just volunteer to help if you need help with any of that, the two Tims.
Okay.
Decision
I do understand. I do understand you're very good at those kind of a things. So, okay. If we get even more confused, we'll let you know.
Okay, thank you.
And any other comments or questions about the bylaws? All right. Thank you. Pretty much the end of the meeting, unless there's any other comments or questions about what is good for all. Debbie, are you trying to?
Let me just, I think that this is an opportunity. I shouldn't pass it up. which I believe is true, that NAMI Humboldt will be offering a family-to-family class starting in January, which is, I believe, an 8-session class for family members or others who care for loved ones with a mental illness. And it's free, 1 night a week, and find out more by checking NAMI Humboldt's website.
Or you could call either of the Tims.
That's right. I let you put that in. I didn't want to volunteer you if you didn't want.
Yeah, and while we're at that, I just wanted to say for anyone that doesn't know that program, it has been vetted. It's been around a long time. There's a lot of experts who put the different pieces together. We're just sharing, but we're bringing all that expertise from NAMI to share with the families. So Allison, did your hand go up again? Is it still there? No problem.
Sorry, I forgot to take it down. I will.
No, that's okay. I just want to make sure I'm listening to you. So thank you, everyone. Then I would adjourn this meeting. You all have a good holiday season. We'll see you in January. Thanks, Michelle, for being here with us. All right. Bye-bye, everyone. Thank you.
You all.
Okay, bye.
Testing. Testing. Testing.